I invite Dr. HARSHUL for his talk about the different optical biometer.
Thank you so much, Dr. Twinkle, for making me a part of your wonderful course, which we have been doing for many years in AIOC. So we all know that once the optical biometer IOL Master 500 was introduced in 1990, it changed the way the axial length, especially in all the parameters, we started measuring with the exactitude. So let's see what are the advances in biometers. So we all know that biometry is the principle of applying mathematics to biology. So broadly, there were ultrasound-based systems and there is optical biometry-based system. So the A-scan ultrasound, it uses sound wave frequency of 10 megahertz and it has accuracy of only 0.1 millimeter. The biggest limitation of ultrasound A-scan is that it does not depend on patient fixation. It just measures the anatomic axial length of the eye from anterior pole to the posterior pole. And second is that it measures from the internal limiting membrane. Whereas the optical biometry, it measures till the photoreceptors, which is the true axial length of the eye. And secondly, it always measures along the visual axis of the eye. So these are the two advantages with optical biometry gives. And of course, resolution is far more better than the ultrasound measurement. So all the biometers, they are basically based on the principle of laser interferometry by Michelson. So IOL Master 500, it is based on the principle of partial coherence interferometry. And it uses a 780 nanometer multimodal luminescent diode. But disadvantage is it only measures axial length optically. And it uses slit lamp imagery to measure anterior chamber depth and other parameters. And so that was the biggest limitation of IOL Master 500. Whereas LensStar and biometer, it is based on optical low coherence reflectometry. It uses a 820 nanometer superluminescent diode to measure corneal thickness, ACD, lens thickness, and axial length. So all the parameters it measures, they are optically measured, which are more accurate. And the K readings are calculated from 32 reference points in two circles, which are at the 1.65 and 2.5 millimeters. As you can see here, two circles of 16 point each. So basically, if we see the difference between partial coherence interferometry and optical low coherence interferometry, the difference is in the two aspects. First is the light source which they use, and second is the optical setup of the interferometer. So in PCI, like IOL Master 500, there is a dual beam setup which is used, and in the OLCR is the proprietary rotating glass cube system which is used to measure the axial length and all parameters. So the disadvantage is that there's a 780 nanometer MMLD which is used in PCI. It creates a measurement peak, and along the in front and behind it creates a secondary maxima. So there is it's not the exact measurement, whereas the SLD which is used in the OLCR, it gives a continuous light spectrum, so it measures all the peaks optically. So if we look at this is the setup of the partial coherence interferometry. We all know that there is a light source which gets splitted by this mirror here, and this light source when combined returning back from the eye, so it measures by this principle, whereas OLCR, it uses a proprietary glass cube system which is more accurate. So that's how we get all the measurements which are optically driven. And look at the AL scan, again it is also based on there are various biometers which I'm now telling you about, that what principle they use and what is the method of capturing. So this is the partial coherence interferometry based system, again AL scan. It uses 830 nanometer superluminescent diode and uses 970 nanometer LED for keratometry, pupillary size, and again 525 LED for white to white. We look at the Alladin. This is again based on optical low coherence interferometry. It measures all the parameters because these are the parameters which we require for all the newer generation formula, as Dr. Twinkle mentioned, the universal Barrett 2 and all the formulas, they require ACD, CCT, lens thickness. So limitations were these, with these biometers were of the penetration in denser cataracts, and they only measure anterior cornea. So now came the swept source based OCTs, this biometers. So IOL Master 700 is one of the device which uses swept source OCT. It uses a scanning rate of 2000 scan per second, a wavelength of 1055 nanometers, and it provides a two-dimensional OCT scan. And so we get all the information about corneal thickness, ACD, lens thickness, and axial length. And it uses a telecentric K in 3 zones, 1.5, 2.5, and 3.2 millimeter, and using a refractive index of 1.3375. So this was the IOL Master 500, as I said, based on partial coherence interferometry, and now this is the IOL Master 700, which uses swept source OCT. And so if you look at this, it's a telecentric keratometry which is used in 3 zones. So we can really see with the use of OCT, we can see the foveal pit, and if there is if we see a foveal pit, then it's a good fixation. If you don't see, so this is how the 3-zone telecentric keratometry is used in 3 zones. We get 6 spots at 1.5, 2.5, and 3.5 millimeters. So the another advantage of IOL Master 700 is that it gives us the total keratometry. So this is the device which not only gives us information about anterior but also about posterior corneal surface. So we don't need to assume anything that what will the posterior corneal power. So it has unique formulas like Barrett TK universal to Barrett TK toric and Barrett true K with TK. So it gives the total keratometry values, which is very helpful, especially in post-refractive surgery patients. It also gives us the angle kappa, that's the Chang CW chord, Chang varying chord it gives. We all know that it should be less than 0.5. Coming to OA 2000, personally I am using this instrument for last many years. It's also based on swept source OCT. It has scanning rate of 1250 and uses wavelength of 1060. It also measures axial length, ACD, CCT, and lens thickness. And it has a placido disc which has 9 rings. So 256 points are there on each ring. And we obtain the K value at different diameters. We can choose whatever diameter we want. And pupillary, this white to white and pupillary size, they are obtained from video analysis. So this is also based on swept source OCT, has very good penetration. Argos is again based on swept source OCT. It gives, it uses 3000 AS scan and wavelength of 1060. And this is the latest from Heidelberg. There's the Anterion. Anterion is again swept source based OCT, uses wavelength of 1300 nanometers. And it measures the aqueous depth from corneal endothelium to the lenticular front surface, and again gives keratometry in the central 3 millimeter zone. So we need all these advanced biometers to use the newer all formulas which are more predictable, more accurate. So they provide repeatable and reproducible measurement in different ocular parameters, and they provide good accuracy in IOL power calculation. Thank you very much. Any questions, I am happy to answer.
Thank you, Harshul, for elaborating all these newer optical biometer in depth.